Okay. I think we still have participants coming online, but why don't we get started? Again, good morning, good afternoon, good evening. My name is Maria Francisco. I'm the project director for the Local Health System Sustainability Project, or LHSS. We're very happy to see so many of you here interested in this topic today. We will be discussing the latest trends in global migration and learn how countries are implementing health systems approaches to ensure access to essential health services for migrants and host communities. In the chat, please introduce yourselves. Let us know where you're calling from, what your position is. We will hold all questions until the end, so please do write these in the chat and we'll try and address these at the end. Okay. We'll begin with a welcome and an introduction from Mai Hijazi, who is the director of the Office of Health Systems at USAID, USAID's Global Health Bureau. Her remarks will then be followed by a presentation from Dr. Santino Severoni, the Director of Health and Migration at the World Health Organization. So let's begin with Mai.
Hijazi, and I am the Director of the Office of Health Systems for USAID in the Bureau for Global Health. USAID is pleased to host this webinar by the Local Health System Sustainability Project as part of our Health System Strengthening Learning Series. The learning series contributes to USAID's learning agenda by convening health practitioners to share evidence from our programs to provide better future support for health systems. Approaches to health system strengthening continue to evolve, and this event is an opportunity to reflect on emerging evidence and the strategic direction for addressing the pressure of migration on health systems. In today's webinar, we'll hear from experts from Fundación Juntos Se Puede, a Colombian civil society organization, Harvard T.H. Chan School of Public Health, WHO, and my colleagues from USAID, as we discuss how health systems respond to migration, particularly through inclusion and integration. The UN, International Organization for Migration, notably states that migration is and has been for centuries a cornerstone of development, prosperity, and progress for many. We are now in a period of time where major transformations are taking place with greater speed and frequency, from climate change to demographic transition, to urbanization and to digitalization. Migration will continue to impact the demand on public services, such as healthcare. Migrants often face serious challenges in their destination countries, encountering unique legal and cultural barriers, including discrimination. They are overrepresented in informal labor markets and often lack access to affordable healthcare. The communities that receive migrant population in turn can face increasing pressure as their resources may be strained by the demand of a larger population. We cannot answer the question about how health systems can respond effectively to global migration without acknowledging our shared global health goal of achieving universal health coverage as part of the Sustainable Development Goals. Universal health coverage means that all people can access quality and affordable health services. We cannot achieve universal health coverage unless we consider the needs of migrants and other vulnerable populations with inequitable access and unequal health outcomes. Integrating migrant populations by giving them access to a host country's health systems requires political will as well as concerted efforts across all levels of government and within communities. These efforts include, but are not limited to, appropriate policymaking, implementation and communication to guide how public and private health providers administer healthcare services for migrants. Policies that systematically integrate migrants into the public health system can also reduce stigma and discrimination by incorporating them into the community. Enabling access to health services that meet the needs of local as well as migrant populations is also key. Health system planners will have to consider service coverage and access for both populations and avoid duplicative service delivery structures where possible for efficiency and cost savings. Engagement with women, youth, and vulnerable communities to adapt health systems, improving equitable access to respectful quality care. Working closely with institutions and partners to develop innovative and multi-sectoral approaches to increase equity in access to and use of health services, and to work towards more integrated and inclusive solutions that benefit all, especially the most disadvantaged groups. And then also addressing both the short-term as well as long-term financing needs for sustainable and affordable solutions, with equity being a central objective of health systems investments alongside quality and resource optimization. As you will hear later in this webinar, Colombia is experiencing unprecedented levels of migration from Venezuela, with many of the migrants arriving with the intention to remain. USAID has played an integral role in supporting the government of Colombia to consider and integrate these vulnerable populations to receive public services, including in the health sector. This support has included technical assistance to the Ministry of Health to develop a 10-year national health plan, which includes a focus on migrants' health needs and support to strengthen the implementation of Colombia's 2021 Temporary Protection Statute for Venezuelan migrants. With USAID support, Colombia is implementing innovative enrollment approaches targeted for migrants, which has resulted in the enrollment of 91,000 migrants into the National Health Insurance Program. USAID's support of the health system to adapt to the pressures created from the mass in-migration of refugees has positioned Colombia at the national and community levels to be better prepared for future challenges. These efforts require dedicated leadership and effective public engagement and communication down to the community level. USAID places great emphasis on local leadership and inclusive development across all sectors and adopting an integrated approach to health system strengthening. We are committed to continue our work to support global strategies to address the healthcare needs of both refugees and migrants, and to advance universal health coverage and contribute to the agenda for achieving the 2030 Sustainable Development Goals. Thank you.
Ladies and gentlemen, dear colleagues, Dr. Midori and USAID representative, I'm very pleased to be with you today for this important meeting aiming at presenting, discussing the landscape beyond humanitarian response towards health system approach. I like actually to start in my intervention with a little provocation, probably I would say towards universal health coverage and primary health care approach. In fact, with my presentation, I'm planning to share with you a bit of information on the global situation and the work that WHO does in regard of moving forward the agenda, the public health agenda on health and migration, but also scaling up assistance and collaboration to member states and key partner stakeholders. With my presentation, I thought to cover at least these four areas, global migration patterns, to give you an idea of what is the numerical element and how this is interacting with the public health sector, the health needs, and the global agenda, and what we are planning for the future. So, as a public health, we do like to juggle with numbers or to work with numbers, and I like always to remind to the audience when I'm presenting our work that when we talk about the public health aspect of population movement, the first message beyond these numbers is that we are talking about a very heterogeneous population. And we're talking about people moving for different reasons. But what is more important, the intensity, the size of the phenomenon is as such that today we are estimating roughly 1 billion people on the move as we speak, with a concerning fast growing of the quota of displaced population and refugees, which in the past has been somehow limited, while in the last few years, I would say, 5, 6 years, had a really a spike increase. We moved from about 60 millions of displaced population, 25 millions of refugees to actually those are already outdated figures, more than 120 millions, almost 150 millions displaced population around the world. Why this is important from the public health point of view? Because this is these numbers, these figures, they're telling us that regardless what is the political landscape, the health sector needs to start to deal with this topic. You need to start to be prepared, need to start to look at the long-term implication, and need to start to promote important overarching principle, which is not only the right to health, but also the most cost-effective from the public health point of view approach, means the universalistic approach, so to prevent excluding parts of population from access to service, preventive or curative. Let's look a little bit what is the mechanic behind the health concern. There is a lot of discussion about migrant, displaced population, refugees might be more vulnerable to health ill, or might be carrier because coming from deprived living context, even carrier of diseases, communicable diseases particularly is a widespread concern. In reality, we see a pretty complex picture, and we documented that a couple of years ago in the first World Report we released to have a look at the status, at the health status of this population. The first point to raise is that given the complexity, the duration, and the perilous, the difficulty of migratory process, where change of lifestyle is also an element constantly present, as also different exposure to potential risk factors, being a migrant, being a person on the move might be categorizing this group of people, or the phenomenon these people living, as a determinant of health. Why that? And we try to explain that in our report, where the element like age, individual lifestyle factors, social community networks. So what you see in these slides at the center of the diagram here in the slides, those are all elements which are impacting, influencing the life course and the exposure to risk factors and the lifestyle of people. The element of migration is an additional layer of complexity, laying above or around those key elements and contributing to impacting on the all elements representing the determinants of health. And this is happening in the all stages of the migratory process, at all stages. So this is an element of particular importance because to us, when we start to look at the health status of migrants, refugees, which totally the attention and the concern from what was in the past, used to be the past, was communicable disease, to actually moving the attention to chronic or what we call non-communicable diseases. The migratory status as an important element of triggering inequity or social exclusion, or limiting access to socioeconomic services at the place of origin because of condition of poverty, of disrupted condition because of crisis, transit because of the transit process, and destination because in many cases the migrants resettling down in a new country, they are starting their life from the lower social level and also getting sometimes the most risky job. So the process of adjusting and migrating is certainly an important element affecting the possible impact of the risk factors and the health outcomes on this population. So when we talk about migrant refugees to be vulnerable by definition, by default, that's wrong. Is the experience of life, the experience of migration, which might be exposing, I like to underline, might be exposing, because in reality, in many cases, migrants might be young and healthy, since this is the main trait factors in being a migrant to be able to go in your place and work. But the migratory process, the displacement process, the moving process might be exposing them to a new situation of vulnerability, and so an increased risk factor for diseases. I'd like to conclude in these slides. What is important is the element of a barrier in accessing health system. In our report, again, one of the findings which came out very strong, very loud from the evidence analyzed was that it's a cross-cutting phenomenon still affecting majority of systems of our member states for a number of reasons, either legal barriers, legal framework related, or capacity barriers, or availability of services, or human resources for health availability and capacity. So there are a number of elements which today they are impacting directly or indirectly in limiting access to health systems and services for migrant and refugees population. In analyzing the access and the reason for this reduced accessibility, we went pretty in depth, taking into consideration also other elements or secondary elements like gender, housing condition, literacy, migration policies, age, discrimination, and so on. Let's look briefly what is the landscape, the policy landscape we are operating, and how things are changing. What is the momentum globally, and with the important repercussions at the country, at the local level. So when we address public health aspect of population movement, we need to bear in mind that for the health sector, in this form of full-fledged engagement, this is a relatively new engagement. We need to consider that in the past, health sector used to limit their own engagement mostly in case of emergency. So the health dimension or the health engagement was appearing only if as a side effect of the migratory process, if the migratory process was at the base of public health concern or health concerns. Situation is radically changed. We start to work systematically on the topic of health and migration in 2008, and in a relatively short period of time, we have seen paradigm shift from only a limited concern that the health system is supposed to be able to recognize public health concern associated with population movement. So we were aiming, advocating for a sensitiveness of the health system towards this topic to a more complete setting of priorities, an area of engagement also by WHO, but also our member states and key partners. In conclusion, what is the way forward? So all this story which I told you translate into very precise objective and actions in order to move our agenda forward with the objective to include the topic of health and migration within the public health domain in all our member states. So our objective is to have a health sector informed, but also capable, policy sounding, and able to address the health needs related to this population. Addressing root causes, the necessity to reorient, I would say to innovate health systems, because opening up to inclusion for refugees and migrants is not a humanitarian aspect, is not an element of charity or compassion, but is a strategic decision in order to minimize the cost for the health system and the impact on the health system. Never spare energy and activity in advocacy. It's important to walk the talk. It's important to continue to explain the situation. The level of political sensitivity is still very high around this area, and the level of misinformation is always behind the corner. So it's very important to keep investing into advocacy as also into strategic communication, a communication which is supported by strong evidence and data. Data is not only graphically at the center of this diagram, but it's probably the most loud gap, concerning gap we generated in health sector, because data related to migration or disaggregated by migratory status are not collected at the country level. Health information systems in many cases are almost blind in this regard, which is the result that regardless the capacity of a country, regardless of the high income or low income economy we are operating, we tend to reinvent on and on the same solution, wasting energy and time instead of progressing, because we don't measure, we don't have data to measure or to define what is needed. Research, for us, this is another paramount priority, investing into research. It's accompany each of our steps of our work at the global, regional, and country level. Then two elements which are pretty complex. Probably we cannot address inequity if we not address migration, and if we cannot address migration if we cannot address the causes of climate changes. Those three elements are very deeply connected or interconnected. So that's why we thought that making better clarity in the nexus or intersection between climate changes, migration, and health is priority. And that's why it's important that the health system is able to put in place, particularly at the community level, particularly at the local level, solutions, interventions, innovations, useful to use the migration associated with climate change as a positive adaptive phenomenon, not as a suffering or reactive phenomenon. Partnership and collaboration, as I said, this is a shared agenda, is a cross-cutting area, and the work needs to be done with non-health partners, because at the country level, most of the political and policy decision in managing migration, they have a tremendous fallout on the health sector. And if the health sector is absent at the table of discussion with a non-health sector, which are designing or deciding the policy and the services or the management of migration, then they need to face the consequences. I thank you for your attention, and I leave you with a contribution, a comment from Professor Abdulrazak Gurnah, novelist and Nobel Prize in Literature of 2021. Professor Abdulrazak is from Zanzibar, and the Nobel Prize was almost received because telling the story of starting a new life in the UK after escaping from prosecution and crisis in Zanzibar. And his attention and sensibility for health dimension, it's a big inspiration for us. Thank you very much.
Terrific. Thank you so much. That was really, really an excellent introduction to the issues. I think in particular, the needs and considerations for mounting an effective public health response to this issue. We will now shift to a panel format. This will be moderated by our LHSS Technical Director, Midori and We will have Jodi Charles, who is a Senior Health Systems Advisor with the Office of Health Systems at USAID, who will reflect on equity in health systems and resilience. We'll hear from Karina Garcia Martinez, who's the CEO at Fundación Juntos Se Puede in Colombia, who will be speaking on barriers migrants face in accessing health services. Paulina Justi is a Principal Health Systems Advisor at APT and our Chief of Party with LHSS Peru. She will be providing insights on experience, including participation of migrants in policymaking. And then Tom Bossert, who is a senior lecturer on global health policy emeritus at Harvard School of Public Health. He will provide thoughts on how the integration and inclusion of migrants can lead to strengthened primary health care, as well as reflections on the impact of differing political environments. Immediately after the panel, we will have a discussion. This will be facilitated by our LHSS staff, Lonnie Crane. Lonnie is a senior advisor for urban health at Save the Children. She also served as the lead author on the LHSS Promising Practice Brief on integrating and including migrants in national health systems. So over to you, Midori.
We have heard our speakers talk about sort of paradigm shift from humanitarian aid to health system strengthening and beyond towards progress towards universal health coverage. So it seems exactly that we are, what is happening is that the issue of migrants' access to health is moving closer to the UHC goal. Which is very interesting. And both of our speakers have pointed out that this is a new engagement. So it is a learning process for all countries and partners. So I hope this panel and this event will be useful for sharing ideas and lessons and experiences with that wonderful panel that was introduced. Jodi, in that vein, I would like to ask you, what do efforts to ensure the integration and inclusion of migrants teach us, show us about achieving health equity for other underserved groups?
Yeah, I think that's absolutely central question. I think, first of all, if we're talking about integration and inclusion of migrant populations, if we're doing that, we are showing that we are delivering on our promises, right? If we as a health system say we want an equitable system that provides essential services for all populations, then that includes migrant populations. And if we're not doing that, then we're not delivering on our promise. And if we say we're improving access, we need to be doing that. If we say that we are trying to improve health literacy, health-seeking behaviors, we need to be doing that. I think in particular, it's kind of a litmus test, right? Because if we mean all populations, then that's not just the easiest to reach. Are we reaching the hardest populations? And that includes migrants. So it's a hard question we have to ask ourselves. Are we doing that? And I think one of the things that's most fascinating about this panel and this topic is that you have a very, you're looking at this very rich, very robust nexus between health equity and resilience, right? Mm-hmm. There are so many areas that we could be focusing our resources and our energy, but I think that nexus really helps to point us in the right direction. So if you look at, for example, the definition of equity, the definitions vary, but essentially we're saying that a system is equitable when it affords every individual a fair opportunity to attain their highest goal. Right? It doesn't say everybody gets everything, but it says everybody has a fair opportunity to achieve their health goals. And if you look at resilience, the USAID definition, there's a lot of similarities there. It's the ability of the people, the communities to adapt to and recover from shocks and stressors, including reducing chronic vulnerability and facilitating inclusive growth. Right? So how do we manage adversity and change across all populations? So you see this really important intersection between these two areas that are absolutely critical, whether we're talking about a specific population or a specific health area. And I think that really tells us a lot about how we are progressing towards our goals.
Thank you. Very interesting. I hadn't made that clear connection, the nexus. Thank you for that, Jodi. Give me a lot of food for thought. La pregunta entonces, Ana Karina, es ¿cuáles son esas barreras que enfrenta el migrante respecto al acceso a los servicios de salud y tal vez otros servicios sociales? En tu experiencia, ¿cuáles son los que resaltan más, los que tal vez haya que enfocarse para aumentar, ampliar el acceso a los servicios de salud que se requieren?
Bueno, primero, gracias. Para mí tenemos dos tipos de barreras, unas barreras que están asociadas directamente a la realidad del sistema de salud, que no solo afecta a migrantes y refugiados, sino también a población de acogida, y es que el sistema hoy está en un momento de fragilidad complejo porque está colapso. Lo que termina pasando muchas veces es que la gente tiene que recurrir a instrumentos jurídicos para poder lograr obtener estas citas dentro del sistema. Y eso implica hacer derechos de petición, eso implica hacer tutelas y dificulta que la población más vulnerable, que no tiene cómo pagar un abogado, pueda hacerlo, y un poco ahí intervienen las organizaciones sin fines de lucro, tanto para población migrante como para población de acogida, para poder ayudar en este proceso y en estos sistemas. Pero el desconocimiento del sistema también yo creo que es una barrera de acceso para ambas poblaciones. Cuando nosotros atendemos los casos, y lo puedo hablar inclusive desde mi propia experiencia personal, yo tuve a mi mamá con cáncer dentro del sistema y vi cómo miles de colombianos no tenían idea de cómo hacer el proceso para solicitar una autorización para una quimioterapia, o qué tenía que hacer yo frente a la atención al paciente para poder lograr que me adelantaran las fechas porque era una urgencia o porque era inminente un tratamiento. Entonces yo creo que el tema de la desinformación es una barrera clave que debemos seguir atacando y que debemos seguir buscando que mejore. Pero también hay otras barreras que sí tienen que ver con la población migrante en específico, que es, por ejemplo, no el proceso de afiliación, porque afiliarse al sistema es sencillo. El problema está en el acceso a realmente la eficiencia del sistema. Entonces ahí hay importante que es seguir invirtiendo en concientizar, en sensibilizar, en socializar a quienes forman parte del sistema dentro de todos sus niveles. No hablamos solo de los médicos, hablamos del personal administrativo, hablamos del personal de seguridad. ¿Para qué? Para que no haya un proceso de estigmatización, porque muchas veces llegan los migrantes y la gente asume que es que no tienen documentación, es que no tienen EPS, y se genera un estigma en torno, o que no tienen cómo pagar, y se genera un estigma a través de esa persona, y eso dificulta el proceso de acceso efectivo al derecho a la salud. Pero también tenemos una población que es sumamente vulnerable, y con esto cierro, dentro de la población migrante y refugiada, que son las mujeres, y sobre todo las mujeres gestantes. También se ha hecho difícil que puedan llevar todo su control prenatal de manera eficiente, porque a veces le dan una cita a los 3 meses y no logran optar por la otra cita hasta el mes 6, y entre el mes 3 y el mes 6, entonces lo que termina pasando es que este bebé puede estar en peligro y puede no desarrollar efectivamente todos sus componentes para nacer sano en el momento en que da luz esa mujer. Y eso se debe a las falencias que tiene el sistema, y no lo vemos solo en población migrante, sino también en población de acogida, pero la mujer se convierte en una persona vulnerable dentro del sistema de salud.
Muchas gracias. Esa es una visión bastante amplia de las múltiples barreras que existen para el acceso a salud. Algunas son efectivamente por el lado de demanda, la información que la gente tiene o que no tiene, la capacidad de navegar por el sistema y también los propios comportamientos de los prestadores de salud en el sistema, ¿no? Sí, hemos visto eso en diversos escenarios, y me gustaría preguntarte ya más en el lado de lo que se puede hacer, o los puntos clave sobre los cuales se debe actuar, digamos, para aliviar alguna de estas barreras o eliminarlas de ser posible?
Mira, desde la Fundación Juntos se Puede, nosotros trabajamos en 3 cosas que creemos que son claves para mejorar este proceso. El primero, información, pero tiene que ser información que sea sencilla para la gente más vulnerable y que sea de fácil acceso. Por eso muchas veces utilizamos los canales de WhatsApp, de Facebook, que aunque no son canales sumamente formales, son canales de acceso sencillo para la población. Lo segundo, también creo que nosotros tenemos que complementar al sistema. El sistema hoy no puede solo, y un poco lo que estamos haciendo desde las organizaciones es generar espacios de gobernanza que permitan articular a todos los componentes del sistema y aportar a que las personas, cuando no tienen cómo acceder y no saben cómo acceder, las organizaciones formemos parte de ese ecosistema para apoyar esto. Pero lo tercero, estoy convencida de que hay que seguir generando procesos de capacitación, de socialización y de sensibilización con los funcionarios y con los funcionarios de todos los niveles. Y se los decía anteriormente, si yo soy el celador del hospital y yo no tengo y yo niego la entrada a un migrante o un refugiado desde la puerta porque no sé, y no es necesariamente un proceso de xenofobia, es un proceso de desinformación del funcionario, yo bloqueo el acceso a un derecho fundamental sin tener conocimiento de lo que estoy haciendo. Entonces, si nosotros formamos y capacitamos a todos los funcionarios en los distintos niveles del sistema, nosotros vamos a lograr que cambie la estigmatización, que cambie la perspectiva y que las personas puedan acceder de mejor manera al sistema. Pero además que puedan ser ellos parte de los facilitadores, que esas personas puedan explicarle al colombiano y al migrante y al refugiado qué debo hacer, que haya pedagogía dentro del sistema. Y yo creo que la sociedad civil tiene mucho que aportar en este proceso de generación de pedagogía, pero también la tecnología hoy nos permite acceso y la mayoría de los migrantes y refugiados tiene acceso a tecnología, a lo mejor no de manera continuada, pero sí tiene acceso a tecnología. Entonces es clave que utilicemos la tecnología para que también haya aplicaciones, páginas web donde la gente pueda autogestionarse y empoderarse de los procesos y no depender siempre de un tercero para poder hacer las cosas. Inclusive, este mismo mecanismo tecnológico le puede servir a los funcionarios públicos que prestan servicios. Si la señora de administración no sabe cómo yo determino un PPT, bueno, yo puedo ir a ese aplicativo y ver cómo funciona ese procedimiento para no negar el acceso al derecho por desconocimiento.
So thank you, Anna, for a very vivid description of the barriers to access to quality health care for migrants and the barriers they face, particularly, both due to mobility as well as to health system barriers and root causes in the host countries. And I would like to turn to Paulina to hear a little bit more about what you have learned about increasing access specifically to mental health through community-level engagement.
Oh, thanks, Midori. And thanks, Anna, for the great exposition. I have to say, first of all, that recognizing mental health problems is like a taboo in our society, in many societies. From people who suffer a problem, that they think that is not right, they don't have mental issues, and from people who work with population. No, we heard from someone of a very long-term NGO that works with vulnerable population after they implement a mental health strategy. We heard them saying we weren't aware that mental health was so important. No, and that is a very graphic understanding that what is the prejudice against mental health. No, and mental health is important for all population, but more for migrants. I could say that most, if not all, migrants have mental health problems, from the condition of getting off their homes, for the problems they face during the road to reach wherever they want to go, And that is more evident in most vulnerable populations, like, for example, LGBT population. No, we've seen we have seen in Peru this specific problem with LGBT population migrants. No, and if we want to tackle that problem, it's very important, I would say, to access the population through the community organizations that they trust in. No, for example, CBOs that are already working with LGBT population here in the country, most of them work with HIV people. No, and working with these CBOs, these community organizations that are or that have already the trust of these people, of this population, no, and helping them to increase their capabilities to identify mental health problems, to link them with community services for mental health, has shown to be a very productive relationship. It's establishing collaboration, no? So you can establish a good collaboration between civil society organizations or CBOs and community mental health services. And they managed to reach a point where mental health services of the community receive and attend the people that the CBOs send to them. And it was in a two-way service, a two-way collaboration, because mental health services send to the CBOs people that has just been diagnosed with HIV to allow them to access peer-to-peer counseling and linking to HIV services. No, and in that effort, you should involve Ministry of Health authorities officials and the local health officials also to allow the collaboration to continue and to scale up. No, and that is a very good strategy to allow migrants or more vulnerable migrants as LGTB to access the services they need, no? To work where they feel safe, where with the people they trust, and with the services that exist in their community. Thank you very much, Darwin.
Thank you. This is certainly a very important topic, and I'm sure we will be learning a lot from different partners in different countries who are tackling the mental health issues of migrants. María Paulina y Ana Karina, una reflexión final para cerrar esta parte del panel.
Siguen existiendo barreras, no solo en términos de regularización, sino dentro de los sistemas. Aunque yo tenga un documento de identidad, eso no me garantiza mi derecho a la salud. Entonces creo que hay que seguir trabajando, hay que hacer un llamado al gobierno nacional de que sí, que los sistemas que tenemos hoy en día son sistemas que de una u otra forma están dando respuesta a algunas necesidades, pero que también están generando barreras y que esto hay que abrirlo al debate. No podemos crear políticas migratorias sin migrantes y refugiados. Entonces, que los migrantes y los refugiados podamos participar en los espacios de construcción de políticas públicas, entendiendo que la migración y el refugio tiene distintas grupos dentro de su misma población. Tenemos la comunidad LGTBI, tenemos población refugiada que no tiene las mismas necesidades que población migrante, tenemos a las mujeres, tenemos a los niños, niñas y adolescentes. Entonces hay que empezar a integrar esta población, construir un modelo de gobernanza que permita que ellos participen, porque además, como los migrantes y refugiados no tienen una voz dentro de los sistemas, si no es a través de la sociedad civil, se construyen políticas sin migrantes para migrantes, y lo que termina pasando es que son políticas que no son apegadas a la sociedad sociedad. Entonces mi llamado en general es que debe involucrarse esta población en esta creación de políticas, pero que además no es solo el marco jurídico escrito en el papel, es cómo lo implementamos, cómo lo socializamos, cómo hacemos que los funcionarios en los lugares más remotos puedan realmente conocer la legislación, porque muchas veces en Bogotá, Barranquilla, Medellín se conoce la realidad, pero cuando tú te vas a Saravena, a Arauca o a los caseríos, a Soledad, cuando te vas a esos caseríos más pequeños, la gente no le llega la información. Entonces tenemos que descentralizar la información para que lo que creemos que sea con migrantes sea efectivo, no solo en el papel, sino en el hecho, pero nunca olvidándonos que muchas de estas barreras incluyen a la población y a la comunidad de acogida y que lamentablemente aquí hay unos problemas estructurales que no tienen que ver con la migración nada más, sino con el país en general. Entonces creo que es un debate que debe ser abierto y que debe incluir a todo el mundo, pensando siempre que los sistemas deben ser sistemas hechos para seres humanos y no sistemas en papel que desarrollen leyes y leyes y leyes que no se coincidan con las necesidades humanas de la población.
Y eso nos lleva al final de este panel. Muchas gracias a ambas. Ha sido una introducción perfecta al próximo tema, que es precisamente el cómo se implementan las políticas. Así que muchas gracias nuevamente. Now we turn to the second panel. We have heard that the paradigm and engagement shift takes us to thinking about migrants within host communities and also to think about migration as a social determinant of health. So that is where this conversation has been leading us. And so, Paulina, from a systemic perspective, what do you think that needs to be done to implement migrant health policies that include migrants into the health system, particularly when we're talking about different levels of government and how these policies need to be implemented at the local levels? So very curious to hear from your thoughts on this.
Okay, thank you, Midori, and hello, everybody. Thinking that the point of entry of this question is that there is a policy to allow migrants to access health system or to be integrated in the country, and that's a big if. No, I think that the first thing we must do is, from a health system perspective, is mapping the system. So mapping the system and gathering all possible stakeholders, not only governmental, but also civil society, CBOs, and local health services, because in that way you will have a shared understanding that what the problem is, what are the interactions of different parts of the system, and what are the levers you have to move to reach that goal that is integrate migrants into the health system. But there are a lot of things that has to be done. I think the first thing you will need is information, data. You have to collect data from migrants, identify who are they, and then analyze. Today, several countries are collecting the data from migrants, but they are not analyzing it, so it's not very useful that. So you need to know about the health issues of migrants, what their perceptions are about the health system, what expectations they have, what are the fears they bring, because many times they are feared to be discriminated or to be identified as irregular and be kicked off of the country. No. And then you will need to evaluate the resources gap you have at the health services level. At the primary care, you have to know what do you have, what do you need. Based on that information, you have this increased population that have these problems, and we have these services. What is the gap? And try to take action to fill it. No. Another thing that was mentioned by Anna in the previous intervention was communication. no? And that is a very, very key issue, because you have to communicate this decision, this policy, these strategies at two levels. First, two levels or three, at the health authorities at the national level, at the local level, and health personnel at the local health facilities. And we talk about health personnel, we are talking about all the personnel who works at the health facility, including the doorman, the administrative personnel, the professional personnel, because many times, as Anna said, in the door the people is rejected because they say we don't attend foreigners here, or you are not going to get attention, so go out. No, they have to know the strategy. They have to know the migrants' rights, because migrants have rights, and you have to work with them to reduce xenophobia. No, and that's a big issue also. And you have to communicate with migrants to reduce their fears, to let them know that they have rights and what their rights are, to let them know how can they access services, what are the processes, what do they have to do, to build trust, not only with the words, but only with the facts when they seek services, no? And then I think you have to monitor, because it's very usual that governments develop policies and that's it. The policy is approved and it will work. But no, there is not the same interest in go to the field and see what's happening. No, and you have to monitor that. You have to invest in monitoring to be sure that your policy is being effective. No, and of course you will have to develop specific policies, specific norms that include migrants. It would be ideal if you can include the voice of migrants on that. And of course, I didn't talk about this in all this time, but you will need resources. So you will have to knock the doors of the Ministry of Finance. You have to convince another political actors that you will need money, no, because you will have more people, and you will have and it could be an opportunity to overcome some problems you have already with your local people, no, to serve adequately your local people, your nationals, no? And I think that if you do have that, you can implement, but this is a big if, no? But it is multifactorial. You have to do a lot of things in order to implement a policy. I have missed something, but I think that are my main concerns. Thank you, Midori.
Thank you, Paulina. Certainly a complex issue. And
yeah.
In the case of your work in Colombia, Tom, I'm sure lots of these things came up in very practical terms.
Yeah.
So tell us a little bit about that.
Well, thank you. And Paulina has just hit on all the major points, I think, and is absolutely right. In Colombia, with the LHSS project there, Comunidades Saludables, survey of the district level personnel and the provincial level personnel about the migration issue. And to reinforce the point that Paulina was making, communication was important because we were trying to find out if everybody knew what the policy was.
Mm-hmm.
And as you might expect in almost any survey, we found variations. Right, so some places would know more than other places, and we tried to target some more communication or more effective action in the areas where we saw that there wasn't knowledge about what should be done. But overall, we found a lot of support for the policy by officials in the health sector at the district level, the local government people. But they were concerned that a large part of the population resisted the migrants being incorporated because they already thought that there wasn't enough money for their needs. Paulina mentions this because I think that's an important thing to take into account, that the resources are already insufficient to respond to the residents' demand. And so if you have an incorporation policy, and this survey showed, and this was one of the major issues that they raised, and as Paulina mentioned, the financing issue is a very important one, was that they didn't have enough money even to respond to the residents. And so they didn't know how they were going to fund the increased demand that the incorporation policy meant. Now, as Paulina mentioned, you can go to the Ministry of Finance with that information. Right? You can make an argument with the economists and say, look, this is a clear problem of supply and demand. We need to have more money to respond to the demand to incorporate this population. But the governments in most of the countries I've worked in already have trouble supplying the amount of money that they can get. Unless they've got an expanding economy, they're going to have to take money away from some other sector, and politically that's very difficult to do. Right? So they're limited. And my recommendation in Colombia was that the donors should take more responsibility. This is an international problem. This is a problem of migrations from other countries. We should be trying to help countries that are absorbing and doing good policies in the absorption to be financially able to do that. But this responsibility as well as a national responsibility. Now, I used to do a lot of studies of sustainability, and we also need to be aware that the donors aren't going to be able to continue to do that forever. So we need to follow, and they're increasingly developing better policies of how to at least incrementally increase the funding at the national level for the healthcare system and for the kind of things that the donors are supporting. So that policy of helping to absorb the migrants should turn into a longer term strategy to make that sustainable with national resources. And one of the things that can be done with that is at the district level. I found in other studies that you can increase the funding available if you decentralize and give more responsibility to local authorities about the health system. That if they have more responsibility, they may take on that responsibility by using their own taxes, their own funding. And we've seen this in Colombia and Chile, where I did some studies, and it was published in WHO Bulletin, that showed that the communities, when they had more responsibility, ponied up more of their local resources. So it wasn't only that the local community would say, we can't do this, we can't take in the more migrants because we don't have more money coming from the top. We can provide some of our own resources because we're responsible for more of what's going on here. Right? And my theory about that is that's because they've been given more functions and more responsibility for making their own decisions about what those resources are going to do. And that's where the decentralization policy becomes important. Because if they don't have any role in deciding what's happening in their healthcare system in the local area, then they have no incentives to put their own money in. So my argument for that is we should do more to encourage them. Now, we can also do it with matching grants. You can say, we are going to help you improve your primary healthcare system or your local system if you bring in a portion of the costs from your own taxes. All right, that's a matching grant policy. And the Ministry of Finance might be interested in supporting that kind of a policy because it means that they can use resources to mobilize additional resources at the local level.
Mhm.
That's one of the strategies that decentralization allows. If you're if the local government can generate its own taxes and it has some responsibility, then it has more. Give you some portion of the need of the funding for this if you bring up your own funding for that. And I like to call that the mafia offer. It's an offer that's hard for a mayor to refuse. A mayor that says, we're not going to take the money from the central government, but that go to the neighboring mayor. It's hard for them to refuse that. And grant is another way to generate more resources and could be tied to the migration issue. Those are my.
Thank you for bringing in that, linking in the decentralization challenges into the migrant policy of including them. But certainly this permeates not only the national level kind of policy, but also the decision-making at all different levels, particularly at the service provider level. So thank you so much for that. And this takes us to our last section of our panel, and I turn to Tom again. We know political and social environments vary enormously from one country to another in regards to migration and migrants' access to systems and services. Through your academic lens, Tom, and your vast experience, can you please illuminate us on the political challenges and nuances that stakeholders need to navigate to advance the inclusion and integration of migrants into local health systems?
Certainly. Pleased to be able to make some comments here. Unfortunately, my participation in the migration issue that we're discussing, the inclusion of migrations, was in Colombia, where we had a lot of political support. So, and as you mentioned, we don't normally have that much political support as we did in Colombia. So I'm going to draw on my knowledge and experience working in other kinds of projects to give some general ideas about thinking about how you can participate in the political process in order to design and implement good policies for incorporation of migrants. You in this is both donors and stakeholders that are in favor of migration kind of policy. Right? The general thing that almost anyone should do is to start with a political analysis, a stakeholder analysis of which stakeholders are in favor of an incorporation policy and which ones are opposed to it, which ones are neutral, how strong their favorability or unfavorability is toward that policy, and how powerful they are. And that's going to change. That's going to be different. As you mentioned, every country has a different set of stakeholders. They have different powers. They have different interests involved in what you're doing. In Colombia, we just were lucky. We had a lot of political support at all levels, political at the district level all the way up to the national level. And I think that's why it's important to do a stakeholder analysis in the beginning. And then it's going to involve very sophisticated understanding of how you can change the balance of those who are in favor and those who are opposed toward more favorability toward the policy of integration. And there are lots of different political choices that you can make to do that. I can't go into all of them now, but I will mention at least two policies that I've been involved in that I think are quite useful. One of them is if the country is decentralized enough so that provinces or states or districts or municipalities have some role in deciding who gets incorporated into their into their health system, then you could work with them. And you don't have support at the national level. They have the authority to make decisions at those levels, and we can work with them, support them, give them funding, give them technical assistance, and those sorts of things for the donors that are trying to help them. And that worked in the case that I was working on family planning for in the Philippines, where the national government was not interested in supporting that kind of policy, but the provinces had power to make decisions, and many of the political actors in those provinces, quite a few provinces, were able to adopt a family planning program that was supported by donor funding. And so that's one policy. The second kind of policy is to work with society and NGOs, organizations that are interested in doing the kind of policy that we think as donors should be done. And you can work with them and hope that not only will they provide some services for some parts of the migrant community, but also they can be pilots. And if you evaluate them, here's my academic hat, that we should do an evaluation to show that it's working. It's solving a problem that even the national government needs to face. And that doing a good evaluation may be one strategy for increasing support at the national level. So that's the second policy. I have some cautions about that, though, and some things to think about when when anyone pursues a policy that not the current policy, and that is, if the donor is supporting this policy, that allows opposition to the policy to try to delegitimize the local stakeholders who are supporting that policy by claiming that they're working for the foreigners and that they don't have the national interest at heart. Right? So you have to be careful that the donors are not so closely associated with the policy and with the stakeholders that that kind of attack can't be effective. Right? So you be aware of that. We often kind of come in and say, we're helping everybody and we're doing good work. And realize that sometimes that can undermine the power and the positions of the people that we think are helping us if we're the donors. The second thing to recognize is, and in some ways, is working only with the private sector. People against you, opposition in particular, because you're not supporting the government actors. We see this in many countries, right? That using funds that are going to the private providers rather than to the government means you're not strengthening the government services that really clearly need support and need to be supported. Be aware of that. It's often better to work with both private and the local government officials and to do something together. A third problem, and this is a problem in many successful policies, is if you do something that makes migration incorporation more attractive, it's likely to increase more migration, right? You're creating an incentive for people to say, oh, if I go to Colombia from Venezuela, I'm going to be able to have health services. It might be better than what I'm having in Venezuela. So you may increase the problem of having more migrants. But the last comment on this is a sad one, right? And is you may be successful. You may be successful over a long period of time, but success does not guarantee sustainability. The example I would use on this is the Seguro Popular, the policy for the poor in Mexico, which was designed many years ago by Julio Frank, successful in a lot of ways through several administrations. And it was sustained. It did everything that we would want it to do. When the Obrador government came in, they had telegraphed from the beginning that they didn't like this policy, and they terminated it. Now, this just shows you that politics is not static, as if you didn't know, right? And that it's dynamic, right? And that you should be aware. Now, one of the strategies to try to deal with that is to try to work with as many different of the types of political actors as you can. People have often said, well, if it's too close to an election, you shouldn't be doing anything because you've got to wait till the next people come into power. My strategy before an election is try to work with as many of the different political actors who might come to power and try to convince them that what the policy you think is going to be effective is useful for them. Be empathetic for their objectives and their goals and try to convince them not to be opposed to what you think is good, and to try to say, we're going to support you if you do what we're doing. And that has worked in some countries that I've worked in, where we've tried to do that kind of broad base. Let's not make it a partisan issue, whether you're in favor of this reform or not. Let's try to work over and gain support. But to do that, you have to be empathetic to the objectives of each of the actors.
Thank you so much to our panelists and to Midori for facilitating. I'd like to invite our panelists back to put their cameras on and join me on screen. We have several of them on the line. And we do have a number of questions already coming into the chat. And I'd like to invite our attendees to continue to write their questions in, and we'll try to get to as many as possible in the next about 15 minutes here. So thank you again. Welcome back to our panelists. I'm going to go ahead and direct some of these questions to our individual panelists, but if you want to come in and respond, please feel free, and we'll try to keep our responses brief so we can get to as many questions as possible. We have a question from Asha in the chat, and I'm going to direct this to you, Paulina. Asha had been asking if there were any success stories at the country level in the African, sub-Saharan Africa, and her question's really related to, data and forecasting and planning with regard to supply chain. But I'd like to broaden that a little bit to the issue of data on migration and data sharing, particularly when we're talking about populations on the move and cross-border populations, and wondering if you can speak to that a bit, Paulina. Paulina, you're on mute.
Sorry for that. Yes, we have worked in East Africa. In East Africa, we have an experience with improving collection in two countries, in the border of two countries, in Uganda, Kenya, Tanzania, and Rwanda. In these countries, we have an experience improving collection and sharing of patient data, that they have high mobility around these countries, these borders, and there was designed and implemented customized and interoperable cross-border digital health information system, that facilitates sharing individual and aggregate patient data and improve patient care decision-making for primary healthcare services. we also have, and that's important because people move a lot around the borders. And we had also the experience in Latin America to standardize the data of HIV migrants along the migration route between Colombia, Ecuador, Peru, and Chile, and managed to standardize what data should be shared, trying to do it as small as it can be, and as taking care of confidentiality also, defining a set of data that should be shared by physicians and patients in order to allow continuity of treatment. This is particularly important in patients with chronic diseases like HIV or TB or others who or chronic diseases like hypertension and diabetes, that need to continue their treatment along the life, along the border they move in. That's it. Thank you, Lainey.
Thanks very much, Paulina. I'm going to direct our next question to Tom. You had alluded to the different actors within the system engaging as many people as possible. And there's a question in the chat from Nilufar Rahmanova, which is, what would be the role of the private sector in integration of migrants in the society and improving the responsiveness of the health system to their needs?
In question, and I think maybe Paulina probably knows more about how to do that than I do. But it seems to me that the private sector is not a sector. So there would be NGOs, like the Colombian NGO that was participating in this, that are going to be more favorable to the kind of things that we want to do and are doing things that donor funding could support, right? That can work to try to improve the services that they can reach. Now, usually those NGOs are not able to reach as large a population as a government program might. And as I suggested in my recorded comments, I think you can, in that case, try to use it as a pilot to show how you can do something, and if it were adopted by the national government, it could be then become a more effective program than the program they have right now. And I think that's one of the ways of thinking about the private sector. The second thing to think about is the commercial private sector, right? And how do you work with them? And again, that may be primarily one of information sharing. And if the program allows migrants to come into an insurance program, then many of the things that insurance programs do to try to incorporate the private sector might then come into play. That the government's going to pay for this person. Therefore, you're going to increase your demand in the private sector. You may have to accept a lower payment for that particular person, but that in some cases where the private sector isn't overwhelmed with demand, that allows them to have at least more services and more population that will bring at least some money to them. So that kind of policy, again, goes back to how you've incorporated the migrants into that system. And I think that's a very important point. I'd like to make a comment about the issue about data, because one of the things politically that you have to recognize is not everybody's a rational actor. And data and demonstrating to the government or to different political actors what would be the best policy does not necessarily translate into their acceptance of that information. Especially in the United States, but in many other countries, the political actors who don't want to do your policy will just reject your data and try to use some other way to persuade people using false data or whatever that this is not right. We should not assume that because we think that the data demonstrates something, that all political actors are going to support that. Now, that's a difficult problem, and it's one that has raised its ugly head for a while, for quite a few years now, that we right now don't have an easy solution to. But it is something that we need to pay attention to, because we tend, the data is going to demonstrate something. But we have to think then, this is why that I made that major argument that we need to do stakeholder analysis, because you need to know who's going to be in favor of what you want to do, who's going to be opposed, and what kind of strategy to do what you want to do or to oppose what you want to do. And information, data, communication, tools, but it doesn't always work in the way that we would like it to work. And that's my caution about that.
Thanks, Tom, and for making the point also that we really need to internalize as well that knowledge and data are necessary but not sufficient, perhaps. I wanted to link that with another question, and perhaps Dr. Severoni, I'll give you the first chance to respond to this. But when we think about engaging these stakeholders, and we heard a very clear call from Ana Karina in her presentation for the engagement of migrants and refugees directly in a policy process, what ingredients or aspects do you think need to be in place to facilitate that participation? And I welcome Jodi if you want to come in as well to comment on that and take that more broadly for equity as well.
Good afternoon, good morning, good afternoon. I believe that the involvement of migrants or refugees into contributing to policy development is still largely insufficient and very sporadic. And the main reason is mostly political, the topic remaining highly politically sensitive and polarizing. And in many countries, when the migration policy is considered, there is always a very clear focus on border management rather than inclusion integration. So the interest, let's say, the political interest to reflect all the stakeholder panorama interest is not necessarily focused in the direction of including and listening to all the interested parties, but rather to identify efficient mechanisms which they can pay back politically in a short period of time, decisions or policy which can show the difference. When we go to the health sector, still we see globally having a privileged observatory looking at the, let's say, behavior of most of the health sectors in our member states, we see that situation is changing, but mostly health sector, they consider to be having a responsibility only when public health complication might arise. So the public health aspect of population movement tend to be coming into the picture and consideration for policy formulation when they are perceived that there is a public health threat, not necessary for an approach looking at the universal coverage and effective primary health care services or inclusion equity or combating inequity in a country. So all those arguments, they are big obstacle, I would say, to the involvement of the migrants, of the users. However, the picture which I want to project is not necessarily so dark. In reality, we see also a change in trend. In many countries, a better understanding, the issue becoming more and more an issue under consideration in the health sector. We heard today previous speakers making allusion to the fact that countries that are taking a political decision to extend the health insurance coverage to large part of the population despite financial economic constraints. In the cases of more advanced progress, we see then the migrant community getting more involved. We don't see how to say, an attention to the issue of migration or listening to the voice of migrants driven by an ideological point of view, but really because the intention is to have a better understanding, better evidence, stronger evidence, better data. This is really an emergency. And listening to the users as an essential component for reality check to see if the policy in place are functioning.
Thank you. And we have about just 1 minute, Jodi, if you want to make a final comment on this one or react to the other panelists' contributions.
No, I think all of this, sort of culminates into really understanding that the approach has to account for these very complex political economy hydraulics. And if we're talking about migrant populations from a health systems perspective long term, all of these things depend on the current political context. Are these migrants temporary? Are they seasonal? Are they staying? Where are they going in the long term? If they are going to continue to be segregated, marginalized, then these political issues that Tom is talking about concerns about resource scarcity, et cetera, are going to always be at the fore. If you're talking about long-term integration, that's a different set of issues. And it's not optional, right? Particularly when we're talking about things like infectious disease. Whether it's a public health threat or any other infectious disease, we are simply not going to be able to achieve our goals unless and until these populations are integrated into the response, right? So part of this is just an epidemiological argument, but it also I know a lot of the questions in the chat are wanting very specific examples, and I think there are a lot of specific examples out there, but so much of this, it depends on the hydraulics of the specific context and how migrant populations are sitting within these very complex environments, and that requires very careful health system assessment, stakeholder analysis, all the things that Tom and Santino and Paulina are talking about. So really just concurring with that. And if we had more time, I would love to talk more about specific examples in other contexts as well. Over.
Thanks so much, Jodi. And in our minute remaining, I have the privilege of thanking all of our panelists for their participation today and the challenge of trying to sum up just a few key takeaways. So just to recap a little bit of the great contributions that we had, we learned that this is an issue that will only increase in importance. The inclusion of migrants into national health systems is a bit of a paradigm shift and a new topic, but more people are on the move than ever before. And a health system's response will require addressing root causes. It will require innovation, taking a systems approach and engaging as many stakeholders as possible while being realistic about the political dynamics and the potential risks of who you engage and how you frame issues to those different audiences. We also heard that to have equitable health systems, to think about health equity, it must include migrants. It can't just be about the easiest to reach, and there needs to be long-term strategy for sustainability and resourcing these responses at a national level. We also heard more about the barriers that migrants face and a very clear call for the direct engagement of migrants and refugees in the political process and in policy development and implementation.